In this PowerPoint, we're going to take a look at various medical disorders and see if they have any effects on sleep, and if so, what types of effects those are. Let's go on to our next slide. Sleep is considered a restorative component for illness recovery. However, the role of sleep disturbances and sleep disorders in the morbidity of most chronic conditions is understudied in children and adults. As a result, it's poorly understood. It is recognized that medical illness can adversely affect sleep quality and that pain, infection, and inflammation can induce symptoms of excessive daytime sleepiness and fatigue. It is less clear, however, how sleep quality affects disease progression and morbidity. Therefore, as sleep medicine professionals, it is imperative we have a basic understanding of what to observe in patients with medical disorders in the sleep lab. Let's go to our next slide. Sleep duration and quality is often poor among patients with respiratory disorders. We can separate our respiratory disorders into two primary groups. Obstructive disorders, this is where patients can get air into their lungs, but they struggle to get air out. And restrictive lung disorders. This is where patients are unable to expand their lungs and take a deep enough breath because their lungs are restricted by some means. I include neuromuscular disorders in my restrictive category because with neuromuscular disorders, they're not going to have the muscle strength to inflate their lungs or suck in as they need to take a big enough breath. So both restrictive and neuromuscular disorders overall are going to end up with hypoventilation problems because they're unable to take a deep enough breath, unlike your obstructive respiratory disorders where they end up with hypoventilation because of the air trapping that occurs. Let's go on to our next slide. We're going to start with asthma. Remember, asthma is a condition of inflammation, and it's the underlying inflammation that makes their bronchioles hyperreactive to various triggers and stimuli, leading to bronchoconstriction and wheezing. For asthmatics, they experience frequent arousals, fatigue, sleep deprivation, irritability, increased asthma attacks in OSA patients at night, nocturnal choking, coughing, and dyspnea, as well as increased airway secretions. You have to remember when we're sleeping, our cough reflex is not working while you're sleeping. So they're not able to clear their secretions while they sleep. If they continue to build up, they will just pool and sit there. As far as your polysomnogram goes, they're going to have less total sleep time, increased wake time, reduced sleep efficiency, increased number of awakenings, and increased wake after sleep onset. Let's go to our next slide. For COPD, this is going to include your emphysema and chronic bronchitis patients. These patients also have problem with air trapping, so they can get the air in, but they struggle to get it out. The symptoms with these patients is going to include dyspnea, chronic cough, hypoxemia, hypercapnia, a lower SiO2, and lower and longer desaturations when they're in REM sleep. On our polysomnogram, they often have reduced total sleep times, increased sleep stage changes, that means more fragmented sleep, and increased arousal frequency. Again, that refers to more fragmented sleep. Let's go on to our next slide. With cystic fibrosis, the sleep effects are going to depend on the severity of the disease. Cystic fibrosis historically has been a disease for children, but with improved treatments, we're seeing older patients live longer with the disease. So you may have a patient in their 30s, 40s, or 50s with cystic fibrosis, whereas a few years ago you wouldn't have seen that. The symptoms associated with cystic fibrosis is poor daytime function and quality of life, thick secretions, persistent cough, poor weight gain and growth, and history of repeated lung and or sinus infections. On their PSG, they're going to have increased sleep fragmentation, poor sleep quality, often normal sleep latency and sleep efficiency though. They will also have frequent arousals due to the need for coughing and oxyhemoglobin desaturations or low SpO2s. Let's go on to our next slide. Restrictive lung disease commonly associated with sleep disordered breathing includes obesity, kyphoscoliosis, which is curving of the spine, interstitial lung disease, which affects the tissue space around the air sacs of the lungs and prevents them from expanding, and pregnancy. Polysomnography suggests that OSA is present in more than 50% of patients with restrictive lung diseases, and nocturnal hypoventilation is present in more than 29% of severely obese individuals. The polysomnographic findings associated with restrictive lung disease include nocturnal desaturations during REM, disturbances in sleep quality, increase in N1 sleep, decrease in REM sleep, increased arousals, louder and more frequent snoring. Sleep onset latency and REM latency can be normal. And then during pregnancy, as the pregnancy advances, sleep quality becomes poor and snoring can become louder and more frequent. Neuromuscular disorders most commonly associated with sleep-disordered breathing are listed below. Neuromuscular disorders may be due to the defects in the neurons or the muscle itself. Nocturnal breathing abnormalities or sleep-related breathing disorders frequently precede respiratory failure during wakefulness by months or even years. Let's go on to the next slide. Neuromuscular disorder sleep complaints include air hunger, intermittent snoring, orthopnea, cyanosis, restlessness, and insomnia. Their daytime symptoms may include morning drowsiness, frequent morning headaches, and excessive daytime sleepiness. Let's go on to our next slide. Diaphragm paralysis. There are two types of diaphragm paralysis, bilateral paralysis and unilateral. Unilateral is much more common, can be due to trauma, surgery, radiation, tumor, or neuropathy, and bilateral is usually due to some type of spinal cord injury or trauma. Polysomnographic findings with diaphragm paralysis include decreased REM sleep and decreased N3 sleep. They have a high risk of developing sleep-disordered breathing during REM because of the loss of their accessory muscle use in this stage of sleep. There's also a greater risk of possibility of OSA. Let's go on to our next slide. Gastrointestinal disorders include GERD, which is caused by a backflow of gastric juices and other contents into the esophagus. This can cause cough, bronchoconstriction, pharyngitis, laryngitis, bronchitis, or pneumonia. And functional bowel disorders, which is characterized by chronic gastrointestinal symptoms without a significant anatomical, metabolic, or infectious abnormality. There are several different types of functional bowel disorders, and so it encompasses quite a few different things. Let's go on to the next slide. In regards to GERD, one large survey in the U.S. found 79% of patients had experienced heartburn at night, 75% which said it affected their sleep. GERD can have a negative impact on their quality of life, and it may be greater in those who experience GERD during the night as compared to GERD during the day. It's estimated that GERD is present in 50 to 60% of asthmatic children and 60 to 80% of adults with asthma. The polysomnographic findings include increased arousal index and decreased duration in the deeper stages of sleep. Let's go on to the next slide. In regards to functional bowel disorders, there are no specific polysomnographic findings available. However, patients do report more dissatisfaction with their sleep quality and increased daytime fatigue as a result of both insomnia-type symptoms and non-restful sleep. Let's go on to our next slide. Endocrine disorders. These disorders can lead to a deficiency of hormones or to an excess production of hormones. Commonly, when your hormones are imbalanced, you experience symptoms such as fatigue, maybe some daytime sleepiness. They usually have problem with weight gain or weight management. So with this group of people, OSA is very common, but it often goes undiagnosed because the disorder itself is associated with fatigue or the disorders. Screening for habitual sleep patterns in OSA are critically important for patients with endocrine and metabolic disorders for these reasons. Let's go on to our next slide. Endocrine disorders, as we mentioned on the previous slide, affects hormone production and the balance of them. To add to that, if these patients become sleep deprived, those hormones can be further affected by the effects of sleep deprivation. Those effects of sleep deprivation include carbohydrate metabolism, a reduction in secretion of insulin, alteration of appetite control. This includes leptin, that's the chemical that tells us we're satisfied and done eating, and ghrelin, which is the chemical that tells us when we're hungry. And we need both of these in order to maintain a healthy diet because it tells us when we're hungry and when we're no longer hungry. Sleep deprivation can affect both of these. And then sleep deprivation can also affect the production of growth hormone. Let's go on to our next slide. With hypothyroidism, which is an insufficient production of thyroid, and hyperthyroidism, where there's an excessive thyroid production, any PSG findings that occur with these two conditions are really due to the presence of OSA. These two distinct disorders do not have any distinguishable PSG findings due to the disease themselves. So with hypothyroidism, some symptoms of this condition include weight gain, fatigue, dry skin and hair, loss of mental and physical vigor, possible nocturnal angina, and frequent OSA. With hyperthyroidism, the symptoms of this condition include fatigue, difficulty sleeping, mood impairment, difficulty concentrating, muscle weakness and tachycardia, and heat tolerance. Let's go on to our next slide. Acromegaly is a metabolic disorder in which there is an excess of growth hormone production after the skeleton and other organs have finished growing. What happens then is they have coarse facial features, an enlarged tongue and hands, and massive jaws. OSA is very common with acromegaly, affecting up to 75% of this population. Central sleep apnea is also common, however, they believe it's caused by different factors. PSG findings that occur in patients with acromegaly are due to the sleep apnea or central sleep apnea, not due to the acromegaly itself. Let's go on to our next slide. Cushing's syndrome is due to having too much cortisol. We know cortisol is necessary for our blood pressure, our blood sugars, and a normally functioning immune system. Cortisol, whether there's too much or too little, can have very negative effects on our overall body. The increase in OSA in patients with Cushing's syndrome is about 32%, and this is due to parapharyngeal fat deposition. The findings on polysomnogram for those with Cushing's syndrome include fragmented sleep, poor sleep continuity, shortened REM latency, and increased REM density. Let's go on to our next slide. Addison's disease. The symptoms of this disease include weakness, fatigue, anorexia, GI symptoms, weight loss, hyperpigmentation, hypotension. Sleep disturbances are reported in 34% of those with Addison's disease and include difficulty falling asleep, repeated awakenings, and early morning awakenings. What they found is if they give hydrocortisone at bedtime, this actually improves the REM latency. It increases their REM sleep, and they have more wake time after sleep onset. Addison's disease is a result of damage to the adrenal cortex. The damage causes the cortex to produce less of its hormones, and due to the nonspecific and slowly progressing symptoms, the disease is not found until the adrenal cortex is severely damaged. Hormone replacement therapy is the treatment for Addison's disease, and it does seem to improve their sleep complaints as well. Let's go on to our next slide. Rheumatologic disorders include chronic debilitating diseases of the muscles, tendons, connective tissues, bones, and joints, causing stiffness, pain, and limited mobility. The most common of these include gout, juvenile arthritis, fibromyalgia, osteoarthritis, and rheumatoid arthritis. Let's go on to our next slide. The problem with rheumatoid disorders and sleep is that you have uncontrolled pain, which leads to sleeplessness, which leads to tiredness, which leads to loss of appetite, which leads to depression, which leads to uncontrolled pain. This is a vicious cycle that is difficult to disrupt and get back on a better path. Let's go to our next slide. Acute and chronic pain have the same polysomnographic findings, and they include shortened and fragmented sleep, decreased slow-wave sleep, decreased REM sleep, insomnia, and early morning awakenings. Fibromyalgia is the presence of widespread pain in combination with tenderness at 11 or more of 18 specific tender point sites. Although the symptoms are numerous, sleep issues exist in all fibromyalgia patients. Those sleep complaints include insomnia, early morning awakenings, non-restorative sleep, poor sleep, which leads to increased daytime pain, stiffness and leg cramps, bruxism, and PLMS. A 2011 study from Norway suggests that women plagued by sleep problems have more than triple the risk of developing fibromyalgia compared to their better-rested peers. Fibromyalgia typically affects more women than men. So there is a question, does the sleep problem cause the fibromyalgia, or does the fibromyalgia cause the sleep problem initially? Polysomnographic findings with fibromyalgia include an increased number of EEG arousals, increased stage N1 sleep, fewer spindles in stage N2 sleep, reduced slow wave sleep, and decreased REM sleep. Let's go on to our next slide. Fibromyalgia's polysomnographic findings include an alpha-delta sleep anomaly, which has also been described as alpha intrusion. There are 3 different patterns for this alpha sleep in patients with fibromyalgia. Phasic alpha, which is simultaneous with delta activity, tonic alpha, which is continuous throughout the low-voltage mixed EEG patterns of non-REM sleep, and low alpha activity. Let's go on to our next slide. Okay, we're going to move on to renal disease. Remember, the function of the kidneys is to remove toxic waste from the blood. It helps regulate blood pressure and water volume and maintain our body's acid-base balance. As renal failure progresses, the kidneys lose their ability to effectively maintain a normal blood pH and filter metabolic waste, causing toxic accumulation in the blood. Sleep disturbances are reported in 80% of the patients on dialysis for end-stage renal disease. On polysomnogram, you'll find delayed sleep onset, excessive daytime sleepiness, diminished sleep efficiency, frequent awakenings. OSA, this tends to be 10 times more prevalent in end-stage renal disease patients, and patients also report a higher incidence of restless leg syndrome and PLMD. Let's go on to our next slide. Infectious disease. With HIV, there's 35% of these patients have alterations in their sleep patterns and sleep quality. There are a number of variables for this: the duration of the HIV disease and its symptoms, depression, daytime sleepiness, anxiety, fatigue, pain, their functional status, and other environmental factors. So it's difficult to say that the sleep patterns and sleep quality is due to the HIV itself or due to other factors. Polysomnogram findings, we see an increase in total percentage of slow wave sleep, an increase in N1 shifts, an increase in REM periods and arousals, an increase in slow wave sleep in the later sleep cycles. We saw decreases in sleep latency and total percentage of N2 sleep. Let's go on to our next slide. Lyme disease, also known as bullseye rash, it is a tick-borne spirochetal illness. If it's not treated, the symptoms include chronic joint inflammation, neurologic symptoms, impaired memory, and other cognitive defects, and cardiac arrhythmias. The effect it can have on sleep includes sleep onset insomnia, frequent awakenings, excessive daytime sleepiness, restless leg or nocturnal leg jerking. Some of the polysomnogram findings are increased sleep latency, decreased sleep efficiency, increased arousals, greater sleep fragmentation, alpha wave intrusion into non-REM sleep, and a mean sleep onset latency during MSLT is typically normal. Let's go on to our next slide. Okay, this is the last of our medical disorders we're going to cover, and it's fatal familial insomnia. This is a very rare prion disease of the brain. A prion is a disease-causing agent that is neither a bacteria, a fungus, nor a virus. It contains no genetic material. They have been responsible for a number of degenerative brain diseases, including mad cow disease, Creutzfeldt-Jakob disease, fatal familial insomnia, and possibly some causes of Alzheimer's diseases. The disease has 4 stages, which take 7 to 18 months to run its course. The patient suffers increasing insomnia, resulting in panic attacks, paranoia, and phobias. This stage lasts for about 4 months. Then hallucinations and panic attacks become noticeable, continuing for about 5 months. Then they have the complete inability to sleep, followed by rapid loss of weight. This lasts for about 3 months. This is followed by dementia, during which the patient becomes unresponsive or mute over the course of 6 months. This is a final progression of the disease, and the patient will subsequently die. There is no cure or treatment for fatal familial insomnia. This concludes this PowerPoint.